This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're with us today. And today we want to talk about something that happens to many people in this country, and that's when your retina detaches, and how we restore that and what medical procedures are used. We're delighted that we've got Dr. Nikisha Kothari with us. She's an ophthalmologist at Texas Health Arlington Memorial Hospital. Dr. Kothari, welcome to the show.
Thank you for having me.
You know, I think to set the stage for our listeners, can you explain where the retina is located within the eye cavity and what does it do to enhance vision?
So the retina is a tissue that lines the inside of the eye. It's almost analogous to wallpaper that lines the inside of the eye. And the way the retina works is it takes the light that enters the eye, it sends it down some nerves towards our brain, and that's how we process that light into an image. So the retina is almost like a tissue that processes things so that we can see.
You know, obviously the retina is an integral part of our vision. Can you explain to our listeners how a retina detaches and what are some of the signs and symptoms so that it can be diagnosed properly?
That is correct. The retina can become detached. And going back to the analogy of the retina being like wallpaper that lines the inside of the eye, when it detaches, it's as if that wallpaper has come off the wall of the eye. And some of the classic symptoms that people will develop when they have a retinal detachment are a new onset of floaters, or kind of black spots that are floating around in the vision. Sometimes you can see flashes of light. A lot of people will describe it almost like a half moon in the corner of their vision. And then certainly a shadow or a curtain or a veil in the vision can be signs that the retina is detached. Now, sometimes before it detaches, you can get a tear. And so it's very important that the moment one has these symptoms, they seek eye care and get seen, because a lot of times we can prevent a detachment from happening if we catch it early. It gets diagnosed by us dilating the pupil. So we put some eye drops in to make the pupil bigger, and then using our different machines, we're able to look at the back of the eye and see the health of the retina.
You know, if a retina detaches, what causes it to detach?
The main reason retinas detach is because we all have jelly inside of our eyes. That's called the vitreous. And with age, it kind of shrinks and pulls away from the wall of the eye. When it does that, it can sometimes cause a tear in the retina, or almost like a little nick in that wallpaper. And then when it detaches, it's because that little nick has run and that wallpaper peels off. So the most common reason is age, because the vitreous separates with age. But there are people who are more prone to getting retinal detachments. For example, people who are nearsighted or have myopia can tend to detach more easily. People who have had cataract surgery and have not had a lens placed in or had complicated cataract surgery can sometimes be at higher risk.
You know, you raised a good point there. Let's assume you've had cataract surgery and have had a lens implant. Are you still prone to potentially have a detached retina?
Yes. You know, the cataract surgery doesn't impact the back of the eye. And so really what determines if you'll develop a retinal detachment is if that vitreous or that jelly has separated from the wall of the eye. Once it has, we call that a posterior vitreous detachment. And once it has and there are no tears in the retina, the chance of a retinal detachment is certainly lower, but not impossible. So cataract surgery is almost a different risk altogether as compared to the retinal detachment.
Let me ask you this. What about trauma?
Yes, trauma sometimes can cause retinal detachments. That's certainly less likely than from an age-related vitreous detachment, but often a direct blow to the eye, like an elbow in contact sports like basketball, or even a ball directly to the eye, like a baseball, that can sometimes cause retinal detachment. In addition, boxers, for example, will have a higher rate of retinal detachment from the repeat blows to the eye. So trauma is certainly a cause of retinal detachment, but much less common than an age-related vitreous detachment, which then leads to the retina detaching.
We talked about cataracts, but can other eye diseases make you more prone to a detached retina, like glaucoma?
In general, no, glaucoma does not increase the risk of retinal detachment. I say that with a caveat. There are different types of glaucoma, but for the majority of patients with what we call open-angle glaucoma, it doesn't increase the risk of retinal detachment.
We talked about the importance of a detached retina. How long can you wait before you reattach a retina?
So there's no time limit as far as when we are able to reattach the retina. However, it can affect visual outcomes and our success rate to get the retina reattached. It's hard to give a time frame precisely, but if you wait many months, certainly it becomes much more difficult to regain vision, even if surgically we are successfully able to get that retina to reattached. So in general, the sooner, certainly the better. And this is something, you don't want to put off for weeks. You want to give your eye provider a call. And a lot of times, once you describe your symptoms, they'll kind of assess the urgency of being seen and can get you in appropriately.
How many individuals are affected by detached retinas every year? And on average, what is generally the age of your patients?
So the average rate, if you will, of developing a retinal detachment every year, it's about 1 in 10,000. And the lifetime risk is about 1 in 300. So not common, but certainly enough that we do see it. And then the average age of patients with retinal detachments is anywhere from 40 to 70. So it is a broad range as to when that vitreous can separate. I will say within that, the majority are in their late 50s and 60s. And that being said, though, trauma can happen at any age. And so sometimes we'll see detachments at a younger age from trauma. In addition, I was mentioning that people who are nearsighted are at higher risk, and sometimes they'll develop detachments at a younger age as well.
Dr. Nikisha Kothari from Texas Health Resources, ophthalmologist and retina specialist. We're talking, obviously, about how to treat those retina tears that sometimes show up in our 50s, 60s, and beyond. This whole conversation is also on our podcast and YouTube channel, The Human Side of Healthcare. We'll be right back.
This is The Human Side of Healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're talking to Dr. Nikisha Kothari, a board-certified ophthalmologist and retina specialist at Texas Health Resources, about detached retinas and surgery to help restore them.
If your left eye has a detached retina, what is the likelihood you might have a detached retina in the right eye at some point?
So the risk of having a retinal detachment in your other eye is certainly higher for somebody who's had a detachment than somebody who has normal retinas. So higher than that 1 in 300 risk. We don't have an exact number per se, but it's certainly higher than the 1 in 300. That being said, a lot of times once you've had a detached retina in one eye, we are monitoring the other eye very carefully and looking for anything that could predispose them to developing a detachment. So if we see any tears in the retina, even if they're asymptomatic from a tear, we would go ahead and treat that, knowing that the other eye had a detachment.
There's some new techniques and innovation coming out, and, obviously the laser is used frequently in eye surgery. I know photocoagulation and cryotherapy sound very futuristic. Can you put those in layman terms?
We fix retinas in a variety of ways. And exactly like you said, we use laser to create a seal between the wall of the eye and the retina around the tear in the retina. So if someone has not developed a retinal detachment yet and just has a tear, we can often do that laser in clinic. And the laser essentially creates a burn around the tear, which creates scar tissue and seals up the tear, if you will. And cryotherapy works similarly. Instead of heat, it's cold, but it works pretty much the same way in that it creates a scar around the tear. Now, if someone's retina is detached, that does require surgery in addition to the laser or the cryotherapy. And there are a few different ways we can fix a detached retina. One is something called a scleral buckle. It's a silicone band that kind of supports the retina from the outside of the eye. And then the other is something called a vitrectomy, or removal of the vitreous, or removal of the jelly in the eye. And we'll replace that jelly with a gas bubble. And that gas bubble actually helps to push the retina back onto the wall of the eye. So our technology has certainly come a long way. Our surgical techniques have come a long way. And so our outcomes have also improved. So it is a bit futuristic sounding, but it's amazing what we're able to do for the retina nowadays. And people are benefiting from that with their visual outcomes.
So in any surgery, there's always an element of risk. What risks are there associated with surgery for detached retinas?
The main thing that I tell patients when they come in with a detached retina is we put the retina back where it's supposed to go anatomically, but we don't have a good way always of predicting where the vision is going to end up. We talked a little bit about timing of surgery and not waiting too long. That gives us more favorable outcomes. And so although that's not quite a risk, I think it's important to understand that we place things back where they are supposed to go, but we may not always know how the vision is going to turn out. Certainly putting it back to the back of the wall of the eye is the best thing we can do for the vision. Some of the other risks are risk of redetachment, or the retina detaching again. The longer a detachment's been around, the risk of that is a little higher. Other risks include double vision if we put a buckle on there, although I will say that's exceedingly rare. And cataract formation is a risk, almost a given, when we're doing a vitrectomy. And so I also like to prepare patients that if they've not already had cataract surgery, by doing the retinal detachment repair, it will expedite the process of a cataract formation.
Once you have the surgery for detached retina, what is the period of time that you really heal and can get back to normal after surgery?
It can be variable based on the type of surgery we do to fix the retina. For example, if you've just had a buckle with no gas bubble, sometimes those patients, even within a couple of weeks, can return back to a normal lifestyle. If we've placed a gas bubble in the eye, it can range from a month to 2 months while that gas bubble's in the eye for things to go back to normal, if you will. And oftentimes, even months after surgery, patients will tell me they're still noticing some improvement. So retina surgery is certainly unlike cataract surgery, where sometimes with cataract surgery, the next day you're noticing improvement of vision. Retina surgery is a lot more of a delayed gratification in that it just takes longer for the retina to heal.
Is there anything individuals can do? For example, if you want to do everything you can to eat healthy, exercise, etc., that helps with many preventions of chronic illness. Is there anything you can do to help prevent detaching retinas?
It certainly doesn't hurt to be doing all of those things for a variety of other conditions that could potentially affect the retina. As far as retinal detachment, really the main thing is prevention. The symptoms we mentioned of new floaters or flashes of light, the moment you notice those coming in to get an eye exam and potentially picking up on a tear or a hole in the retina that could lead to a retinal detachment before it occurs is really the best thing to do. Also, if your eye provider thinks you're at high risk of a retinal detachment, routine eye exams are warranted as well. So not necessarily anything you can eat or exercise to do to prevent retinal detachment, but being seen appropriately based on your symptoms and risk factors is very important.
Do detached retinas seem to be hereditary?
That's a great question. Certainly nearsightedness or myopia can tend to run in families. And you will hear, oh, my father had a detachment or my grandmother had a detachment. It's not as though there's one gene, like genetic conditions that cause retinal detachments, but myopia or nearsightedness can tend to run in families, and then that places them at a higher risk for retinal detachments.
Dr. Kothari, this is Thomas. I'm wondering, with this topic, are there any myths out there on the street that we should be aware of?
I don't know that there's necessarily a myth, but I think a lot of people think either it's their cataract progressing or that they can come in and just get laser treatment for a detached retina and not get surgery, or that once we fix the retinal detachment, their vision will guaranteed go back to what it was before the detachment. So I think those are common misconceptions as far as detachments go. So I do think it's helpful to kind of understand that, a lot of times it does require actual surgery, going to the operating room to fix retinal detachments.
We're talking with Dr. Nikisha Kothari. She's a board-certified ophthalmologist and retina specialist at Texas Health Resources here in the Metroplex. You can also catch both of our interviews today on our podcast and our YouTube channel, The Human Side of Healthcare. Dr. Kothari, I've known several people who have had this. Fortunately, haven't myself, but this really comes out of left field for people in their 40s, 50s, and 60s and beyond, doesn't it? It's a real surprise when it happens.
It does. And when I tell patients that everybody at some point in their life are going to develop a posterior vitreous detachment or that jelly separating from the wall of the eye, most people are surprised to hear that. And so, of course, we talked about the numbers, and it's much less common to actually get a tear or a detachment, but everybody is going to get a vitreous detachment. You may be asymptomatic from it, like the majority of people. But the more you talk to people, you'll probably hear people say, oh, yeah, it developed a floater and got better on its own. But yeah, I noticed that in my 50s or in my 60s.
Steve, what do they say? Getting old is only for the brave?
Yeah, Thomas, you and I sure know about that. Dr. Kothari, final word, and thanks for being with us.
I think probably the biggest takeaway I'd like to leave people with is knowing what the signs and symptoms are, which I think we've talked about. And number two, don't wait. I think all too often I see people who thought, oh, maybe I just need new glasses or my contacts are just not quite right. And ultimately it turned out it was a retinal detachment. And if they had come in sooner, we might have different outcomes as far as their vision. So don't wait. And, there's always a way to get seen either by a general ophthalmologist or a retina specialist, but getting in to be seen is the best thing.
Thank you, Dr. Kothari. We will be better prepared now if a retina tear surprises us suddenly. Hey, when we come back talking about surprises, Dr. Glenn Hardesty from the ER up at Texas Health Presbyterian in Plano and Prosper, we're going to talk about some of those surprise accidents and injuries that can be prevented from his perspective in the ER. Plus the weird and the bizarre, including live snakes. Hear it when we come back on the human side of healthcare.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We decided we want to talk to Dr. Glenn Hardesty, who's an emergency room physician at Texas Health Presbyterian Hospital in Plano and also in Prosper, about things you see in the emergency room, especially during the summer, sometimes around holidays, and things we can do to help prevent some of those problems. Dr. Hardesty, welcome to the show.
Thank you, Stephen. I appreciate the opportunity to have a few words with the public and hopefully avoid a few emergency department visits with what we see of ways of preventing certain injury patterns.
In the summertime, in an emergency department, what are some of the common ailments you deal with?
Well, in the summer months, we generally deal with more injury related than illness related. That said, falls, people outdoors playing, we have people with burns. Certainly there are a lot of us amateur grill masters out there, and starting campfires with accelerants did not always end well for people. The use of, sometimes people a little overindulge in the holiday season, sitting out by the pool or just out in their backyard. So certainly alcohol and intoxicants end up with folks coming to the emergency department. Any number of reasons people would have a traumatic injury, something would fall on them, they would be outside, climbing on ladders, falling off, trying to get, frisbees out of trees would be one. Boating accidents, water accidents are another thing that we see. As an avid boater, I like to, impress upon the importance of boater safety, making sure that everybody has a life jacket that's on board and that the captain is properly trained to operate the boat. That tends to be where we have more injury, when folks are not used to operating a watercraft.
You mentioned alcohol, and since you mentioned boating, how important is it for adults, especially if they've got children, to avoid alcohol use when they're driving a boat?
Well, I can find no place for alcohol or any intoxicant for that especially when you have children on board and boating. If there is one thing that correlates to predictable injury, it is alcohol use and boating. But with kids, you need to be especially vigilant because of other boaters around you. You could be distracted, turn your attention away for a minute, run over and potentially run over another person in the water. This time of year, it's everybody that has something that floats is out there in the water. And you've got to be careful of all the other people. Once again, any type of intoxicant doesn't have a place, especially with children. If you pull them on the inner tube, making sure that you have a dedicated person to watch them so that they don't fall off and get left out in the lake. Believe it or not, some crazy things like that can happen.
We hear a lot about, if you're going to drink, have a designated driver for an automobile. That would be a great rule for a boat. Would you agree?
Oh, absolutely. And just like with a car, if you're drinking and driving, you can be charged with the same with a boat. You're boating while under the influence. And even more important with boats, because people are not used to being out on a boat. Most people don't drive their boat on a daily basis, so they're not as familiar with its operation. But I think that's a great point.
You mentioned being around lakes. It's hot. It's summertime. It's Texas. We have snakes. What do you say to help prevent snake bites? Because I'm sure you see those in the emergency room.
We see those in the emergency department, and also we spend a lot of time outdoors. And in fact, had a situation about 2 weeks ago at the Boy Scout camp where a friend of mine almost stumbled upon a rattlesnake. So it's being very vigilant in the environment and aware that the snakes are out and where you might find them. I always encourage, if you're going to be out in an environment where you have snakes, is to invest the money in some type of boot, preferably a snake boot. That way, pair of boots is a great insurance plan against a very costly hospital bill in the event that you're bitten by a venomous snake.
Is there any concern in Texas you could be bitten by a snake and you go to the emergency department and you don't have the antivenom needed?
That would be a very rare event. There's really 3 snakes we worry about here in North Texas, and it's the same antivenom that we use for those snakes. So we don't need to identify the snake. We just need to know that you were bitten by a snake. If you can get a picture of it, that's great. Don't try and capture that snake because it's already let you know it's going to bite you once. So if you try and capture it, get bit again, you may, the first time they may have let you off the hook and give you what we call a dry bite. The second one, they may say, well, I already told you once, I'm going to tell you again, this time I'm going to put a little venom in there. So let's, keep in mind, don't try and capture the snake because you can get bit multiple times. Also, want people just to get away from the snake. It wants to get away from you. You want to get away from it. But there's some people that feel like they need to, address the snake and kill it. We've had several cases where people have thought they have killed a snake and in fact probably did, but were bitten by what they would call a dead snake. So if you find yourself in that situation, please don't pick up a dead snake. It can still bite you. If it's an exotic snake, like a cobra or something that comes from a reptile, from like the reptile zoo at Dallas or Fort Worth, then they would keep those antivenoms around, or we would hope that they keep those antivenoms around. But the general, person out enjoying the 4th of July does not need to worry about not having any antivenom. Major hospitals will carry it. Now, there might be some smaller hospitals that may not have it on hand, but those patients would be transferred to a larger facility that had the antivenom on hand. There's a lot out there in pop culture. You're not bitten by the snake and run 10 steps and then fall dead. These the snakes here are hemotoxic. It takes time. Sometimes people can get injured rushing to the hospital. Take your time. Don't get yourself hurt and get in a car wreck. Also, don't try and fix it yourself. All the tools out there that try and suck the venom out have been proven not to work. So it's best to spend your time getting to a hospital that can treat the snake bite.
If one of our listeners did get bitten by a snake and they came carefully, as you said, a friend drove them carefully to the ED, they come in and they say, Dr. Hardesty, I know a lot about snakes. I just got bitten by a copperhead. Would you immediately do the antivenom, or would you watch and observe in case it was, in fact, a dry bite?
That's a great point, Steve. Yes, in fact, many bites are dry bites, and we would observe the patient before we administered antivenom. For 2 reasons. 1, it wouldn't be necessary to give it to them, and 2, the significant cost associated with antivenom. So we would look for signs of envenomation, which would be swelling and pain. The last snake bite that I saw was a dry bite. 2 little fang marks, and we watched the patient for 4 to 6 hours, and we didn't have any swelling, no signs of envenomation, and they went home about their business.
We've talked about being around lakes, being outside, celebrating. Fireworks comes into play. I assume in the ED, you see people that have been injured by fireworks.
Oh, absolutely. We have had multiple injuries from fireworks. And, obviously it's a big explosive device that does not always go off as advertised or predicted. Certainly you can have burns and significant burns at that. Patients can have injury from the projectile, getting hit by the projectile. People also can get hurt running away. You want to light people want to light it, and then you want to move away from that as quickly as possible, knowing most of the time this is in the dark, and then people are running. You might find yourself stepping in a hole, breaking an ankle, that sort of thing. And also eyes. We find patients, the sparks that come up can affect the eyes as well, especially those sparklers in kids. Kids love the sparklers, are a lot of fun for the kids, but keep in mind that those embers are burning very hot, and they have a way of finding their way into the eye. So make sure to be cautious if you're using that with children. I'd recommend some eye protection, because those little hot embers would not do well for kids' eyes.
I would imagine also if people are out camping, if they're outside where it's hot, they bring some snacks and food, but they don't exactly refrigerate them the way they should. Do you see food poisoning or food-related problems when people come to the ED?
Yes, potentially we do see foodborne illness. Now, we don't have a definitive test in the emergency department to say, yes, this is clearly food poisoning, but we have to get the story, and this treatment is very similar for majority of the cases where, it's symptomatic treatment. But certainly that is something that we see, especially around people handling raw meats, unwashed vegetables. It's such an easy thing to prevent. Making sure that you cook your foods, and then don't put those same foods that you cooked back into the tin that you brought the raw meat out to the grill on. They sell little half-quarter tins at the store. If you get them in bulk, they're about a quarter a piece. Well worth the investment to have two of those on hand, one for the raw meat and the second one for after you've cooked it and letting it sit and preparing for serving.
We're talking to our friend Dr. Glenn Hardesty from Texas Health Resources, Presbyterian Hospital, Plano, and Prosper. Find out what he recommends to put in your summer first aid kit. That's ahead. Also, you can catch our podcast and our YouTube channel where these interviews are in their entirety. That's the human side of healthcare. More tips from the ER next.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're continuing our conversation here with Dr. Glenn Hardesty. He works up at the emergency room in Prosper and Plano at Texas Health Resources. We're focusing on things you can do to be safer in the summertime and things you really wouldn't expect might happen that could send you to the ER. Steve?
What about people that get a bug bite and they have a severe allergic reaction? I bet you see that in the summertime.
Oh, do we? We do see a fair number of insect bites, some bee stings, where people can have a true, what we call an anaphylactic or allergic reaction, where they're bitten or stung and they swell up, they have trouble breathing, and that happens very quickly. If they have an anaphylactic reaction, that's a very quick evolution of the disease process. For those patients, most of them know about it and will carry an EpiPen. But for those that, for whatever reason, might be their first time to have that, or they get caught without their EpiPen, you might see them in the emergency department. There's some lesser symptoms that can occur, and we would typically treat those patients with IV fluids and maybe some steroids in the emergency department. That helps decrease the inflammation and reserve the EpiPens for the true anaphylactic reactions.
I know people ride motorcycles throughout the year, but I can imagine in the summertime when it's a lot warmer, people are out riding motorcycles, bikes, much more frequently. Do you see more bike-related and motorcycle-related accidents in the summer?
We do. Bicycle helmets are critically important for kids when they're out and about. Motorcycles, on the street, they need to be wearing a helmet. Off-road, they still need to be wearing helmets. I can't tell you the number of patients that we've seen with severe head injuries that end up in long-term care facilities because they weren't wearing their helmet. When I think of motorcycle accidents, I can think of probably two or three that really come to mind, and how those people I know wish they had put on a helmet before they got on that motorcycle.
I know summertime may not promote this, but I was actually driving my car down the street the other day, and this individual was texting and walked right off the curve in front of me texting. Luckily, I was going slow enough that I stopped. Have you seen, as an emergency room doctor, accidents that were triggered by people texting?
Oh, I think texting and driving, or texting, anything that's distracting you, certainly whether you're driving a vehicle or walking across the street. We're not as pedestrian friendly in Dallas-Fort Worth as we are in other parts of the country, but certainly I think people get very caught up in whatever they're texting at the time and walk straight out in the middle of the street. Especially sort of the younger generation, that you see a little more of that. They get immersed a little more than those of us that are older and can't read the screen as well, and not necessarily tech savvy. I think, as we proved earlier in the interview.
You guys didn't talk about fish hooks.
Oh, my favorite are fish hooks. I'm an avid outdoorsman, and spend a lot of time with the Boy Scouts. So, fish hooks are a challenging one, especially those treble hooks, because you'll see people get a treble hook in, then they'll cut it right at the skin so that the rest of the hook doesn't get in, and in fact, then we can't get it out. So if you have a treble hook in your hand, do not cut it off. If you're going to cut anything off, cut the sharp barbs that are still sticking out if you have to do something, but don't make a bad situation worse. We can numb it up and take it out. It's something we do on a routine basis, and get you your tetanus shot too while you're at it. Single hooks, they can go in pretty deep, especially if you're some of the big catfish hooks. We need to be real careful about getting those out, because that can take a little bit of flesh with it. Or if you're even down on the coast and you're going after some really big fish or sharks, you might find those hooks, if they get in you, they really need to be taken out almost surgically.
You're listening to The Human Side of Healthcare, and we are talking with Dr. Glenn Hardesty. He's an emergency room physician with Texas Health Resources, working up in Plano and Prosper. All right, help us put a first aid kit together. What should go in it?
Well, the first thing is a big dose of common sense. I would say there are a couple of basic things to put in a first aid kit. One is some kind of wound cleanser, be it iodine, be it some type of chlorhexidine, just so that you have that in there. An ample supply of some type of gauze or something to help clean the wound, and to also bandage the wound when you're done. So you would have a non-sterile, or one that's not in a package, that you would clean the wounds with, and the one that's individually wrapped in those packages, that's the sterile one that you would put against the wound after you're through cleaning it. I would have I would put an ACE wrap in there, because that can hold bandages in place. It can also help if somebody's injured. I like to have a first aid kit where everything in there does a little, can fill one or two rolls if we need to. I would have some type of irrigation solution, be it sterile water, or just even contact solution would work well. That way you can help clean out wounds, or if people get something in their eye, that's a good thing to have on hand. Also a pair of tweezers. You can't imagine the number of splinters that you have to get out, or will find a use for, with having a pair of tweezers in there. And I would also make sure I had a pair of gloves. You want to make sure that you protect yourself first. Certainly we want to help people, but you want to make sure that if you have exposure to blood or bodily fluids, that you protect yourself first. When you talk about first aid kits, now you're getting to the heart of my Boy Scout stuff. So we can go on for some time there. We're doing a high adventure here shortly, and I'm putting the kit together for us to take on our high adventure with us.
We've been listening to Dr. Glenn Hardesty, ER physician with Texas Health Resources in Plano and Prosper.
Thomas, I want to play you something, and after we listen to it, I'll explain why.
Guinea pigs are very much like humans, that they're very susceptible to COVID. And so they put two cages right next to each other with a little very light breeze blowing from one cage to the next. And in the first cage, they put some guinea pigs that had COVID and became very sick. And then they put a second cage, next to it with healthy guinea pigs to see if they would become infected by the air coming from that first cage to the second. And sure enough, those guinea pigs, the healthy guinea pigs, became infected. Almost all of them became very sick and then had severe lung pathology. Then they put basically a surgical mask material on the healthy guinea pig's cage, sort of simulating putting a mask on the healthy people. And sure enough, a few of the guinea pigs got sick from the sick ones, but it took much longer for them to get sick, so their immune system had time to kick in and protect them. And none of them died, and they had very mild illness and very mild pathology in their lungs. And then they did it a third time. This time they put the mask material on the cages of the sick animals and repeated the experiment. And now a tiny number of them got sick, and they were just mildly sick. The illness again was delayed, and there was no lung pathology in those. What this proves beyond a doubt is that a mask is very efficient. It's protective by two ways. One, it makes you get less virus. You're exposed to less virus. If you even get infected at all, you will get a less severe infection, and you will survive it.
And that story has been a classic here on the human side of healthcare throughout COVID. Dr. Robert Haley, UT Southwestern Medical Center.
You know, Thomas, the reason I played that is July 4th, lots of people out, large crowds, just like Dr. Haley said, sick people infecting others. One of our best defenses is to wear a mask. And as the numbers continue to go up and the case count, we're seeing more people in our hospitals. Now think back to last summer. In fact, think back to last July 4th, where we had an explosion of Delta variant here in North Texas. We don't want that to happen again. And one of the things we can do, and it's very simple, is wear a mask. And that will help protect all of us. You know, enjoyed this show, Thomas, and we hope folks will join us next week for the human side of healthcare. Be safe and wear that mask.